indicator of the eventual outcome. Ocular injuries are evaluated according to the Ocular Trauma Classification System. The grade of injury is an important prognostic indicator for visual outcome, and the visual acuity is a strong predictor of final visual outcome. Studies recommend that patients with a GCS of 3 to 5 following resuscitation should not be treated unless there is an associated operable hematoma. These patients, unfortunately, generally have a poor prognosis, which includes the economic and the psychosocial burden of these survivors. Simple wound debridement and closure are suggested management. Aggressive treatment of patients with a GCS of more than 7 is indicated. And patients with a GCS of 6 to 7 are individualized according to the bullet tract, degree of brain injury, clinical situation, and the expected outcome. It should be emphasized, however, that the management decisions with regards to neurotrauma should be made by experienced neurosurgeons. And if doctors are managing patients in a rural setting, it's important to pick up the phone and phone a neurosurgeon. Just a disclaimer that I'm not an ophthalmologist or ophthalmology trained, but I'll just foray into the ocular trauma classification system. According to the system, mechanical eye injuries are divided into closed and open globe injuries. These groups are then further subdivided. Open globe and closed globe trauma can also be subdivided according to the zones of injury. As indicated here, the visual acuity at presentation is used to grade ocular trauma from 1 to 5. And this, as you'll see in the next slide, corresponds to outcome. This study was done by Gangor and colleagues, and it was shown that the grade of injury corresponds to unfavorable results as indicated. Unsurprisingly, the type of weapon had a definitive effect on visual outcomes. Note the poor visual outcomes associated with hand grenade and mine injuries. Next, we come to important aspects with regards to imaging. Computed tomography is the main and most important because it provides excellent bone detail. It demonstrates the missile path, bone fragments, and localization of retained projectiles. And it definitely assists in planning ways of removal. MRI is contraindicated in gunshots, and they provide inadequate imaging of the bones. And angiography is important in suspected vascular injuries. Just a few complications of retained bullets, which includes chronic sinusitis with mucocele formation, a formation of a cutaneous fistula, which can chronically drain from a paranasal sinus cavity. There's a possibility of a rhinolith formation, meningitis, chronic pain syndrome, and lead poisoning. The possibility of malignancy is also there. In 1981, Ben David and his colleagues published a case report on a plasmacytoma arising in the vicinity of a foreign body in the nasal cavity. But it's unknown if this is directly a cause of the bullet or just a mere association. With regards to managing sino-orbital gunshot injuries, there is no standard due to the relative low incidence of these injuries. It, however, goes without saying that a multidisciplinary approach is indicated, and preferably trauma doctors and emergency medicine physicians should coordinate the management plan. Prompt resuscitation and diagnostics should be initiated on presentation of these patients with a focus on the primary and secondary survey according to ATRS principles. And furthermore, a high index of suspicion for CSF leak should be maintained in these patients. Patients with associated cranial cerebral injuries should be managed by neurosurgery according to their GCS. Conscious patients with non-urgent intracranial injuries should have their orbital pathology managed by ophthalmology, and ENT should be involved in the elective removal of sinonasal foreign bodies. The following summarized guidelines are suggested in patients with a CSF leak following a sinoorbital gunshot injury. They should be admitted for neurological observations. If the patient deteriorates, a repeat CT is warranted, and management should be expedited if required. A low threshold for the diagnosis and treatment of meningitis is crucial. This should take into account that the time interval from onset to death of meningitis can be as short as 6 hours. Pneumococcal vaccine should be given at presentation. Prophylactic antibiotics are not routinely indicated in patients with a CSF leak. And definitive repair is indicated with leaks persisting for more than 7 days, or in the case of a meningitis. The indications for bullet removal in general includes the following: bullets found in joints or the globe of the eye, associated CSF fistula, bullets leading to nerve impingement, bullets lying within a vessel lumen, those causing lead poisoning, bullets superficially seen or clinically palpated, and bullets crucial for medical legal purposes. However, in all other cases, the indication should be critically reviewed prior to removal. With regards to bullet retrieval from nasal cavity and paranasal sinuses, the following should be considered. Local primary surgical wound management should receive attention during the initial presentation. Repair of orbital and paranasal sinus defects should be performed within 6 months, taking into account the possible risks of removal. And in most of these cases, endoscopic sinus surgery is safe and provides excellent visualization. The following are suggestions with regards to bullet retrieval for bullet fragments located in each of the sinuses. For bullets in the frontal sinus, endoscopic removal is indicated if the bullets are adjacent to the sinus ostium and not embedded in bone. In other cases, external approaches with the frontal trephine should be considered. An ethmoidectomy is indicated for bullets embedded in the ethmoid sinuses. For bullets in the maxillary sinus, an endoscopic antrostomy, Caldwell look approach, or a Denkers procedure can be considered. And bullets in the sphenoid sinus require special care, as these can be in close proximity to the optic nerve or the internal carotid artery. Right, so coming back to our patients, we'll just have a look at the definitive management of the 2 patients presented earlier. In the 14-year-old female, ophthalmology performed a left eye evisceration. Remember that this patient had no visual acuity in the left eye. The patient had an uneventful post-operative course and was discharged for follow-up to the ENT outpatient department for elective endoscopic removal of the sphenoid sinus bullet fragment. However, 2 months following discharge, the patient presented with complaints of persistent clear rhinorrhea and was diagnosed with a CSF leak. Consequently, an endoscopic repair of a left lateral sphenoid CSF leak was done, with simultaneous removal of bullet fragments in the sphenoid floor. Intraoperative findings included a shattered left lateral wall of the sphenoid with an encaphalocele. The sphenoid sinus was packed with fat, and this was followed by a cartilage graft to the anterior wall and a septal flap. The post-operative course was complicated by epistaxis. After a period of nasal packing, she was discharged on day 9 following surgery. Coming to our 30-year-old male, during his initial hospital admission, he developed a meningitis secondary to a CSF arteria, which resolved on a course of intravenous antibiotics. Ophthalmology performed a right eye evisceration due to a grade 5 injury in his right eye. ENT performed a canal wall down mastoidectomy for access to remove the foreign bodies in his right ear and to remove a defect and to repair a defect in the tegment tympani. A second stage surgery was performed to remove bullets from the paranasal sinuses. An endoscopic transnasal transseptal approach was used to access the sphenoid sinus, and 2 bullets were removed, and no CSF leak or bleeding was noted intraoperatively. A loose fragment of bone over the internal carotid artery caused by the gunshot injury was left in place. So in conclusion then, sino-orbital gunshots are very rare. However, they may present with high mortality and most are associated with intracerebral injury. Initial resuscitation and diagnostics should be done according to ATLS principles. Neurosurgical management should be done according to the GCS. Treatment by ophthalmology is indicated if no intracerebral injury. And elective removal of sinonasal projectiles via endoscopic sinonasal surgery is safe and provides excellent access. Thanks. Thanks, guys.
Thanks very much, Gerrit. Indeed, quite rare and quite privileged to see this series that you and your colleagues published. Thank you very much for that presentation. It would be fantastic to hear from comments from around the continent, perhaps other countries as well, and what the trauma situation there is like, and any experience with regards to sinonasal gunshots is concerned. Professor Libbe, who's the supervisor or the senior author of one of those studies, if she's on the call, it would be fantastic to hear some comments from her as well.
Yeah. Okay. Yeah. Thanks, Gerrit. I'll go take this thing away.
No.
Okay. One thing that I actually wanted us to look at. Are we still on? So one thing that I thought it was really interesting to look at during this article, which we haven't really published, is your comment on, MRI is contraindicated, for patients with bullet kind of injuries. So I was asked to remove a bullet from a patient, I think it was a pellet, that was in the posterior orbit, and she required an MRI of the brain for other reasons. And this bullet has been there for more than 10 years. And the radiologist refused to do the MRI before we removed the bullet. And then I did some research on bullets, and most bullets are made of lead, either lead, copper, and steel is very uncommon. And steel is the only part of the bullet that would actually be magnetized, or it would influence the MRI. So you kind of wonder if radiologists always believe, that one shouldn't do an MRI. So I think a very interesting study, and we actually started doing that, is take a whole range of different bullets and only to find that none of them are magnetized. So in the case that I had to remove the posterior orbital bullet, it was a big intervention. It took us about 4 hours because it can be very difficult to find these bullets specifically in the eye. And afterward put it on a magnet, and it wasn't magnetized. So in fact, that MRI surgery was done in vain because they could have done an MRI. So it's just one thing to keep in mind, So if you do have a patient with an injury or a bullet in situ, it might be worthwhile to try and find out, when that happened, what kind of bullet it is, to determine, whether the MRI is really contraindicated. I think the big thing for us is after these massive injuries, and you have multiple skull base fractures, is, when to repair it. And often it's not good to repair it immediately. There's so much damage, and you might have a couple of skull base fractures, and it's best to wait and see which ones heal. And you get sometimes surprised that most of them will heal, and the bullet will get a little capsule around it, and it's much easier to remove that capsule with a bullet afterwards, and then repair whichever part of the skull base needs repair, wherever it's leaking from. Because if you try and repair all of those defects, you might end off rather being better off with a craniotomy. So maybe there's some other questions from around the country.
Thank you. Thank you very much, Professor Libbe. Thank you very much for your comments. And I don't see any questions yet. It would be really nice to hear any comments from anyone else from around the continent, perhaps. Often when you look at gun-related violence and statistics across Africa, the two main culprits in terms of countries are South Africa and, surprisingly, Ethiopia as well. So it'd be nice to hear any comments perhaps from anyone joining us from Ethiopia. Or in the meantime, maybe perhaps...
Could I ask a question?
Sure, Prof. Fagan,
yeah.
Please.
The two issues, the one is, Prof. Libbe, is this the kind of surgery that you should be doing if you can't deal with the CSF repair, if you encounter it? Or should the occasional sinus surgeon rather refer to an expert center? And the other is sympathetic ophthalmia. Is that a real issue that we have to be concerned about here? Can you comment on that?
I don't know enough about sympathetic ophthalmia to comment. Perhaps Prof knows more than I do. Okay.
I think to answer your question.
Yeah.
So just to answer Prof. Fagan's question about whether you should refer, I think it very much depends where the bullet is sitting and how long it's been there. Often you find that it's actually quite easy to remove if it's kind of encapsulated after a couple of weeks. I think if it's in the maxillary sinus, it's pretty safe to go and remove it. You do a big middle meatus mantrostomy, you can do your Denkers, but even if you have to do a Paul Luck, that's also acceptable. So I think that would be kind of most surgeons would be able to do that. I think where you have to be careful is if the bullet is lodged in the sphenoid sinus, and specifically if it's kind of attached to the lateral wall. There you have to be very careful, and probably do angiography, definitely do angiography beforehand to make sure you don't have a false aneurysm or you pull on that bullet and it might be attached to the carotid artery. I think, yes, you must be able to repair a CSF leak if you're going to remove a bullet from the sphenoid, especially if there's a fracture of that wall. And then we very seldom see the bullets in the ethmoid sinuses, but you're also very likely to get a CSF leak there. But usually these traumatic leaks are quite easy to repair, just with a little bit of abdominal fat that you would plug that hole and then try and swing a pedicled flap from the septum, or you can use the middle turbinate or mucosa from the lateral wall, whatever tissue hasn't been damaged. But usually you've got a pretty good success rate with
that. Thank you very much for those comments. We have two raised hands. Dr. Kenneth Baidu from Ghana. Please go ahead.
Good morning, everybody, and thank you for a nice review. Tessie, can you allow me to share some images from my screen?
Absolutely. I think you should be good to go, Dr. Baidu.
Can you all see the screen?
Yes.
Tessie, can you see my screen?
Yes, I can see the images, yes.
Yes, so this is a case I was asked to review this past Monday. And it's just a coincidence you are discussing it today, and it's quite timely too. He had an injury in the right eye from a gunshot, and the bullet is lodged now in the left infratemporal fossa. And this happened in September. So the question now is, should we go for it or not? And that is what I've been trying to make a decision on. I don't know what Prof. Lebe, Prof. Fagan, and any other person on the call thinks about this. So that's the pellet.
So Prof. Fagan and I are looking at each other. So I'm saying it's in his territory.
Sorry?
No. So is the patient symptomatic?
No, he's up and about. His concern basically was, will this thing affect him? And I told him, I don't think it would. It's 8 millimeter. So honestly, my candid advice to him was we should leave it in place, but if he wanted, we could go chasing it.
And how long has it been there?
It's been there since September. It happened on the 12th of September last year.
Yeah. So my feeling would be to, if he's asymptomatic, to leave it. And we'll see if Prof. Fagan agrees with that, and rather manage it when it becomes problematic, because it will be nicely encapsulated. If you go transnasally here, you can definitely get there, but you'll probably have to come you'll either have to do a Denkers on the left side, or come from the opposite side, the right side, and go through the septum. So you'll have to do a posterior septectomy, then remove the posterior wall, and you'll have to most likely ligate the internal maxillary artery. And because you're digging through the pterygopalatine fossa and all those nerves, the patient will have subsequent numbness, if he doesn't have anything now. So he's asymptomatic now, but with the surgery, he's got pristine sinuses. You have the potential that he's going to struggle with sinusitis. He's going to have crusting from that perforation. It's all things that with minimal morbidity, but you'll have a patient now who becomes symptomatic, and the numbness will probably bother him the most. So I think from my opinion, I think it'll be easy to get out if you have to, but you'll have to have you might even need to look at angiography before that, because it's very close to your internal maxillary artery there. And if Prof. Fagan he agrees. Yeah. So we both agree just to leave it.
That's all right. Thank you very much, and have a good day.
Thank you very much, Dr. Baidu, for sharing that case. I see Dr. Mainasara's hand was up as well. Dr. Mainasara, please go ahead.
Thank you very much for the very wonderful presentation. We see a lot of gunshot injury in Nigeria because of the Boko Haram terrorists we see. And I was also consult in a military hospital. I've seen about 5 cases of bullet lodged in maxillary sinus, 1 in maxillary sinus, and some in the sphenoid sinus. Well, just to comment that endoscope actually help in localizing the bullet. Like I have a case that had previous attempt in other hospital which they cannot localize the bullet intra of. But with aid of endoscope, I was able actually to localize and actually remove one of the bullet in the maxillary sinus using the Denker's approach. And one I use both wide, medium metal and strobing and a cardwell lock to localize the bullet and actually remove it. There is one that actually refused to sign consent for removal. It was a pellet in the sphenoid sinus. Thank you very much for the wonderful presentation, and thank you all for the comment.
Great. Thank you very, very much. I think we're coming to a close to our talk for today. Perhaps any other comments from around before we close? It's nice to see no comments from Kenya. We're a relatively peaceful population. Nice to see no comments from that side of the continent. But perhaps Dr. Filiu and Gerrit, any closing comments from your side?
Tasia, thanks for hosting. No closing comments from my side. Thank you.
Great. Thank you very much for everyone that was able to join us today. Indeed, a very nice meeting with shared presentations from across the continent. We look forward to inviting you and welcoming you this Friday for our case presentations. Otherwise, till then, take care and have a lovely day ahead. Thank you very much.